Okay. So I promised myself when I was preparing this one that I wouldn't make it too long, and I thought elbow cases, there's not that many. So I thought, I'll do it like a 20-minute lecture and it'll be fine. And then as I started to do it, I ended up with 70 slides. So I'm going to have to speed up and slow down in various elements of this. There are some of my slides that are heavy on text, and they're not intended to be viewed live, if you know what I mean. I put them on there because I think sometimes people often ask me, what would you say in this question? What would you say in that question? And so for some of the cases, I've literally written out the script of what I would say if I was given a particular question on a particular case. So the idea is, if you go on the YouTube channel when this is uploaded later, you can actually pause it and read the script that I've actually written. So I'm just going to make this full screen, unless, yes, that is working. So the objectives of this talk essentially are to discuss some of the common elbow cases for the FRCS. I think it's important that people just realize that it's probably not a huge amount of elbow cases that come up, but they are overrepresented in the trauma viva for sure, because it's easy to scare some of the lower limb surgeons and the spine surgeons with a dislocated elbow or something. And a lot of the time it's taught quite badly in training, and so that's probably one of the reasons why it's also taught. I see someone's raised their hand. Mohammed Shayet, do you want to ask a question before we get started?
Sorry for interruption. This is just for
Viva. Okay. That's for Viva. He raised his hand for Viva, not for questions.
Oh, I see. All right. I'm sorry. I'll carry on. So one of the other objectives is to offer some possible answers and how I would approach some of the stations. I think that's previously when I've discussed with people about the FRCS, that's one of the things that they've asked for. And then I'm going to provide you top tips along the way for each of the cases. And then at the end, as we always do with a FRCS mentor session, we'll have opportunities for people to practice. So the first case I thought would come up, that there aren't that many elective elbow cases that come up in the adult path, I don't think. I prepared this one in my preparation. If you get shown an X-ray of a obviously deformed and arthritic elbow, this may be a long case, an intermediate case. It may be a short case. It may be a viva. If it's an intermediate case, then you just approach it like any other new patient in clinic. 5 minutes history, 5 minutes for examination, and obviously with COVID, it's mainly talking through what you'd examine for. And then 5 minutes for your management plan, which includes how you're going to investigate and work up the patient. I think it's important in this kind of rheumatoid elbow is don't get thrown by the fact that it's an elbow and you haven't seen much rheumatoid elbow. Just imagine it's a rheumatoid knee. You still take this similar history about pain and function and past medical history, other rheumatoid issues that they may have. Don't forget to ask screening questions about the cervical spine. They particularly like that in any rheumatoid case, because if you go down the route of surgical intervention, if you haven't mentioned that there's a high rate of cervical disease that may preclude a standard general anesthetic, and patients may need at the very least a lateral cervical spine X-ray before any general anesthetic procedure, then it just shows that you really haven't seen or treated many rheumatoid patients. So always remember that. So I've written here, don't forget the patient attached to the elbow. Okay, that's really important. They may be on lots of other medications, they may be on monoclonal antibodies, all of these things that you need. It's nice to ask in the history, even questions which in the exam you think, why would anyone ask that? Like, do you know the name of your consultant rheumatologist? So, because I'd like to copy them in to any correspondence. You don't, what if they say Dr. Smith? You don't know Dr. Smith, it's a made up thing. But the fact you ask that question tells the examiner that this person has treated rheumatoid patients in the past, and they understand that it's not just a one person show providing care. In the examination, it's very straightforward, really. It's, range of motion, integrity of the collateral ligaments, which is very important. the quality of the skin, especially in patients that have been on steroids for many years, and always examine the hands and wrist as well as the shoulder, because anything you do to the elbow may be precluded by the hand and wrist function, as well as the ability to move the shoulder. And so there's controversy over whether you start distal and work proximal, or proximal and work distal. I take a pragmatic approach and discuss with the patient what's the more troubling thing, because you can give them improved elbow range of motion and pain relief, but if their hand and wrist are so bad that they can't function, then it doesn't mean very much. And conversely with the shoulder as well. Always think about function and have something in your answer in the examination about assessment of function, even though it's the elbow. So with the elbow, you may ask about feeding and combing hair and toileting and things like that, because you actually need more flexion than extension for function, but questions like that will help answer that. If it's a short case, it's very to the point. So just describe the x-ray. Often you'll get given a prop, which will be an x-ray of the elbow, like I showed you previously. Just state the relevant things that you need to make an assessment. All right. Straight off the bat, you should identify that doesn't look like a normal arthritic elbow. And you don't see much elbow arthritis anyway. The vast majority is from inflammatory arthropathy. So your first question would be, I'd like to take a history to see if this patient is known to have an inflammatory arthropathy, what medications they're on, what previous treatments they're on, if they've got any other issues with any of the joints. Being to the point and direct will get you to where you want to get to, and just be direct, right? You can say this is an AP lateral radiograph demonstrating this, but just say this is very severe, advanced degenerative change of the ulnar humeral and radiocapitellar joints. This picture is more in keeping with an inflammatory arthropathy, and so I would like to take a history, examine the patient to look for this, and in particular, I want to treat them based on their level of pain and quality of life associated with this particular joint. So discuss the management holistically. Get the rheumatologist involved. You have to mention that, and really with rheumatoid management, the mainstay of treatment is non-surgical. To get to a point where someone needs an elbow arthroplasty, you really have had to exhaust a lot of conservative measures. A lot of these patients will be managed quite effectively by the rheumatologist with repeated steroid injections and splints and things like that. But if they do get to the point where they require surgery, you need to understand what things are relevant to work them up for that. So we've mentioned the cervical spine, we've mentioned function. Assessment of the collaterals is important if you're looking at surgery. And then really, when you're talking about this kind of case, it's understanding what can be, from a surgical point of view, what can be managed with soft tissue procedures like a synovectomy and debridements of osteophytes, and what is beyond salvage. And in the vast majority of cases, the mainstay of treatment is an arthroplasty in very advanced disease like this. It's pretty straightforward. If it's synoviva, it could be a basic science or an adult path. If it's basic science, it may be about the anatomy of the elbow, it may be about the pathophysiology of inflammatory disease, or it may be about tilted elbow replacement principles. If you had to pick any of those three, I would hope that you'd want to pick the latter, because even though you probably know the least about that, it's the thing where the bar is quite low in terms of knowledge required. So I've mentioned this in my other FRCS mentor webinars where we talk about FRCS tips and tricks. You go back and watch that. But essentially, the harder the station sounds, the easier it often is to pass, because it's not, total elbow replacement principles are not a thing that most people can wax lyrical about for 20 minutes, right? People know very basic information about that, and people are expected to know very basic information about that, just enough to get by as a general orthopod, not as a tertiary specialist elbow surgeon. If it's adult path, it's usually about management principles, and then that leads on to like total elbow replacement principles. Usually very basic questions, which we'll go on to. So you may get asked, what do you see here if you get shown the X-ray? You may get asked then, how would you assess this patient? These are very simple starter for 10 questions. And you may get asked, what treatment will you offer the patient? You know, that's a natural flow to that kind of station if it's a viva or a short case. If it's a long case, obviously they don't interrupt. They just, you know, they say, this is a patient, please see them. And you just approach it like you're seeing a new patient in the clinic with, you know, a very brief GP referral letter in front of you, often not even there. They just read it out to you and say, this patient's referred for elbow pain. That's it. But if it's a short clinical case, they may lead you through with these simple starter questions. So these are my script answers. I'm not going to go through these, but you'll see when you pause this and watch it back later that there's a lot you can choose, and you're not going to actually just recite this. But I just wrote it out because this is the kind of stuff that I wanted to get across in an ideal scenario, but actually, in reality, you'll forget some bits, you'll put in others. The only thing I would say is if you get asked these open, broad questions, try to qualify everything that you're asking for. So if you see here with my assessment of the patient, every little bit of information that I'm asking for, there's a reason for it. And if it's not obviously clear, I will make it clear by explaining to the examiner why I'm asking for that information. And then it's same with the treatment. The treatment is always the same for things like this. You know, it's always about symptoms and quality of life. It always starts with conservative treatment. It always involves physiotherapists and rheumatologists. And essentially, you're just being very broad. You don't commit to anything. But if you see something that's very advanced like this, you can go one of two routes. You can say, well, this person, if they fail conservative measures, will require a total elbow replacement. A much safer strategy is to just put the X-ray out of your mind and almost the patient out of your mind, and just talk generally about how you manage rheumatoid elbow. So conservative and surgical can be soft tissue procedures or bony procedures. Bony procedures tends to be arthroplasty in severe cases. Arthroplasty can then be qualified into these types of arthroplasty, etc. Then they may move you on to, okay, if you get onto, you've done a good assessment, they're happy with that, they've asked you about treatment principles, you've mentioned rheumatologists, you've mentioned steroid, you mentioned modified disease modifying drugs, and they've failed all of that, and you've introduced, you should always try and end your answer with something that you can then talk on about. That's a quite common technique that people have described. So if you go back to my spiel, the last sentence would be, for severe stage of disease, arthroplasty is the mainstay treatment for those that have failed conservative measures. Then you stop talking. So you've ended that little bit of information to that answer, to that question that they've asked you, with elbow replacement. So the natural progression is nice to have a good flow to a station, which isn't always the case, depends on the examiner style and how you're doing and whether you're ticking the right boxes. But often in a really smooth station, you basically end with something and they pick up the thing you just ended with and ask you about it. And so in this scenario, they may ask you, well, what types of elbow replacement do you know about? And this may sound like a scary question, but actually you need to know very little. Or they may ask you, what approaches do you know for total elbow replacement surgery? And most of us would never have seen one in training. I think I only saw, a handful in training, and I wanted to do shoulder and elbow surgery. So it's really not a very common procedure that's done these days. And it's, the median and the NGR is less than 5, I believe, per surgeon per year. So it's not a common procedure. But you need to know a little bit about it. So, and then if you're doing really well, the mark, if you get asked, what is bushing wear with regards to elbow replacement, you've passed, like without a shadow of doubt. And if you get onto that, then they're really trying to push you to get really higher marks. And so these are my stock answers for that. We can talk a bit about them a bit later on, but I'm not going to bore you too much with that. I had to look at what a bushing was, to be honest, for the FRCS. A bushing is an open cylinder that is basically a liner that reduces abrasion. It's used in mechanical engineering all the time, and in elbow replacement, it's very common. And bushing designs have evolved over the years to be a bit thicker and a bit more congruent, based on failures of previous generations of elbow replacements. But you don't need to know too much about that. Lots of different ways to do an elbow in terms of approach. You should just know that for rheumatoid, the vast majority of implants used are semi-constrained. They're always linked because of concerns around the soft tissue. Not always, I'd say the vast majority are linked because of concerns around the soft tissue envelope around the joint. And they usually are semi-constrained because that allows for stability without overloading the cement bone interface and having early loosening. So the top tips for this station is just keep it simple. Just don't get bogged down with rheumatoid elbow. Just think of it as a rheumatoid patient with a joint that they've come to you about. Just the fact that it's an elbow shouldn't make it any more complicated, right? So especially in the long case, people get really bogged down with it, but actually the elbow component of the long case is actually quite small. A much larger component is the patient, and who is this patient that's coming to you? How fit are they for surgery? How much have they exhausted all the other treatment measures for this? If you want to score well, you need to understand total elbow replacement principles and limitations of those, just very broadly, very simply. And then if you really want to dazzle your examiners, talk about GIRFT. It's very topical for elbow replacements at the moment. Any BEST members out there will have seen the President newsletter, which references this. And there's a lot of discussion about which centers should be GIRFT centers and essentially the centralization of care for elbow replacement surgery because it's done so infrequently. So the next scenario, this is likely to come up in your PES viva or your trauma viva, is a lateral condyle fracture. And it should start with any trauma case. You guys coming up to part 2 of the exam should already have a pre-prepared spiel in your mind about any trauma case that you get. And it will be something about ATLS versus isolated injury. Just, I don't want to labor this too much, but if the scenario clearly points towards a single joint, single limb, isolated low energy injury, don't just keep banging on about ATLS. You want to just get out of that as quickly as possible, but you should mention it, right? So you could say something like, I'm assuming this is not a high energy or polytrauma event that may require mobilization of the trauma team and a resuscitation via ATLS principles. And if it is an isolated injury, I would then proceed to assess this by taking a history and examining the limb for the following. So try and roll that into one thing. It's unlikely they're going to show you a pediatric condyle fracture and the scenario is actually all about ATLS, okay? So don't get bogged down with ATLS. And don't say neurovascularly intact. That just drives everyone crazy. It's just so lazy. When you're talking about a limb, just demonstrate at the very least, which nerves could be possibly injured in this kind of case. So, very simply. And when it comes to pediatric cases, always take a history where you understand the implications of the questions that you're asking. So the timing of surgery has 2 implications: how swollen it's going to be, but also delayed presentation for NAI. The mechanism of injury, were they observed, were they not observed, how high were they? These are all things that will glean to the examiner that you understand why you're asking these questions and what the implications of these questions are. How high were they when they fell? Again, that implies the energy that's transferred through the fracture site. What's the developmental history like? Have you had any previous injuries, especially to the elbow? Because there's a lot of children that have had malunited supracondylar fractures and then they have another fracture to their elbow a few years later. That's important to know if you end up needing surgery, that this is already a distal humerus that has been fractured and has healed. Always mention that you examine the nerves around the elbow. The skin condition, they don't tend to be open injuries, but they can be. Examine the whole limb. Children are notoriously bad at telling you exactly what they've fractured, so you have to examine the whole limb and just check for radial pulse in everyone with a limb injury. And then your management should focus on what you do in the emergency department, but you want to get out of that as quickly as possible to talk about your definitive management. So you may get shown an X-ray like this. you may just get only one view, and it may be an X-ray like this from like the 1950s, and that's usually what my experience has been in the FRCS. You know, the radiographs and the images taken very quite reasonable quality, you know, reasonably poor quality, I would say, and quite old. You may get these starters for 10. You know, what's the diagnosis? How would you assess this? And I'm not going to go into this, only to say that if you say I would request an AP with 20 degrees elevation and column views, internal, external, oblique views, then already to the examiner, they're thinking, okay, this person understands this injury and understands the fracture planes in which occur in the lateral condyle fractures of the elbow, and that's why they're asking for these things. You know, you don't need a CT for these cases, especially in children. They won't ask you how to classify this injury. Everyone always gets worried when I put in questions like this, but I would say this is a great topic to know one or two classifications for it. They may ask you what's the blood supply to the lateral condyle if you do particularly well, you're talking about management, and those are the answers. So in my exam, in my preparation, I decided to go with the VICE classification because it's very simple to remember. It's 3 types: type 1, 2, and 3. Type 2 and 3 need surgery. Type 2 can be done closed. Type 3 needs to be done open. And it's also interesting because it uses contrast and II fluoroscopy, which a lot of generalists probably won't have seen used. It's quite a relatively modern thing to do. The examiners will want you to talk about the Miller's classification, which is type 1 and type 2, depending on whether it enters the fracture line exits lateral or through the trochlea, and that determines whether it's a Salter-Harris 4 or 2 injury. The blood supply, it's important to know there are 2 end arteries from the radial artery, essentially the middle collateral artery and radial collateral artery, and they enter laterally and posterolaterally. Also postlaterally and posteriorly, and they basically meet in the ossific nucleus. And it's important because if you start dissecting around the back of the lateral column, the posterior aspect of the lateral condyle, you will strip all the blood supply and the patient will get AVN. And so that's why they're asking you that question. And so I always get really paranoid when I do these cases, just to stay in the midline of the lateral condyle and anterior. So they may ask you how you manage this, that's reasonable, and they may ask you what the common complications are. And then if you're doing really, really well, they may ask you how do you treat a malunion, but I'd be very surprised if anyone ever gets to that point unless you've totally smashed it and you're a peds ortho savant of some kind. These are my stock answers. KYs or screws doesn't really matter. People get really bogged down with this. As long as you understand why you've chosen one over the other, I don't think it really matters too much. Common complications, stiffness is quite common. I was surprised when I was looking this up for my exam that stiffness takes a lot longer than the average elbow injury in children to resolve. Tardial nerve palsy, not that common. But can happen. You can also get a condition called pseudovarus, where you get this callus and lateral prominence, which if you measure the angles isn't actually a valgus deformity. Can whoever's got their microphone on please just mute? That'd be great. Thank you. And then a fishtail deformity is essentially a deformity you get secondary to AVN of the trochlear nucleus ossification center. How do you treat a non-union or a malunion? It's very, very difficult. You need to just basically say, look, this is very difficult, and assess the patient for function, the degree of the lateral prominence, get a CT scan, measure the carrying angle, refer them to a specialist center that has expertise in doing this. And if they, if you're like doing really well, they may ask you to what's your favorite osteotomy? There's numerous, but I'd be very surprised if they ask you that. I would say this article is fantastic for this topic by Dan Perry in Liverpool. I read this article several times, and this is the VICE classification that I mentioned earlier. Again, really, really quite a very concise and to the point review of this injury. So the top tips for this, actually, it's a very easy station to score highly on. You need to know the blood supply to the lateral condyle. I think that's a reasonable thing to ask someone because that has implications when you go to theatre. And classification again, watch my FRCS tips and tricks video, because people get really worried when I say you should know classification, because as I mentioned before, you don't need to know it to get a pass for this station, but if you do know it, and it's not that hard to learn one, it's very easy to demonstrate knowledge and awareness, because this is one of the few areas in orthopedics where the classification actually is incredibly useful in guiding management. So next is radial neck fractures. This could be in the P's viva, which it often is, or in the trauma viva. It's very similar, the approach would be very similar to a lateral condyle fracture. And the station usually starts with assessment, and then they very quickly explore your decision making. So the first stage of decision making will be how you're going to manage it after you've gotten out of A&E. The second stage is in theatre usually, and this is quite a common flow to this station. So they may show you an X-ray like this, or even less displaced than this, and go, what would you do? And then you've really, you and ah, and some, I'm sure some people would say leave it, some people would say take it to theatre. This case is a little bit more displaced. I think this one you'd almost certainly go to theatre. But they may ask you, what is it? Very simple questions. They may ask you what the ossification center is around the elbow, especially if you may get this in a basic science viva, and the actual radial neck fracture has got nothing to do with the actual station. It's just a prompt to get you talking about something. Or they may ask you when those ossification centers fuse. And those are the answers if you want to go back and look at this. How do you assess the injury in ED? Again, very simple, basic question. You're not getting anything harder than that, really, to start you off. How do you manage it? That's really where the meat of the question is. And so, again, management really is about understanding where your threshold is for displacement. So I decided, based on reading around the topic and some experience treating these injuries, less than 2 millimeters or less than 30 degrees, I would leave. Anything greater than that, I would treat with a closed reduction. And then inevitably they'll ask you, what happens in theatre, right? What reduction moves are you going to do? And guaranteed they won't work, all right? And each one you'll try won't work. And then they'll get you to a point where it's not reduced, and they'll ask you, are you going to open it if you don't volunteer it? And that's where this station usually goes. And these are the other things that they may ask you. But my approach was to first use the Columbus technique, which is a 2-surgeon technique, 1 surgeon trying an inline traction and varus, and then a lateral force over the radial metaphysis, and then the other pushes the radial head medially. And then I was going to go, if that fails, I was going to go to the Eschmark bandage technique. If that then fails, I was going to use a blunt K-wire and just to Kapanji the head back onto the shaft. And then if this fails, then I would consider the Metazo technique published in 1993, where you use a tens nail retrograde, and you basically use the tip of it to engage and disengage the fragment, and then flip it back onto the metaphysis. And then I've said in my stock answer, a perfect answer, if you like, when I was preparing, if this fails, I would not proceed to an open reduction, as there's a high rate of AVN. I would split the elbow and refer it on to a pediatric upper limb specialist. And then usually they'll say, okay, well, you're the pediatric upper limb specialist, what are you going to do? How are you going to open it? And then I would would describe a standard open reduction. Common complications: HO, synostosis, AVN, stiffness are all possible. AVN is an incredibly difficult thing to treat, and so that's why opening these is usually a recipe for disaster, because you're setting that child down a path where they'll often end up in a specialist elbow surgeon's clinic, and so it's best to do that without burning bridges and opening it, in case they do get some of those complications. And this is taken from, I think this is taken from this review article. Again, a very good review article in the same journal, which I've talked about in my previous videos. Gives you a very concise overview of these injuries in like 8 pages. So the top tips for this station: the flow of the station is important. You want to get to theatre as quickly as possible without missing any of the important bits along the way. The case is usually, this kind of case usually is all about the nuance of decision making, as I mentioned. So just be sure to explain your thought process. A lot of the time, there's no right or wrong answer, but that sequence of reduction maneuvers, I've got a good thought process for, and if they wanted to ask me, I would explain to them that's why I would do it. Same with not opening it. I can explain to them the rationale. I would not open it, even though I understand this is not an adequately reduced fracture, because the sequelae of complications from open reduction of these injuries in children is quite significant, and I've not got enough expertise to manage this effectively. But as a day one orthopedic consultant in a trauma unit, I think most people would expect you to be able to manage most of these in your unit. All right. And that's basically what you've shown with these answers in what I've described. And if you've never done an open reduction of a pediatric radial neck fracture, the FRCS is not the first time to do it. Okay, so that's a common top tip, is don't do operations for the first time in the exam. Next is a terrible triad type case, usually in the trauma viva. Again, this station can be difficult if you don't know your elbow anatomy and the elbow stabilizers. Decision making is again important, and you can't just pass it on. You will be asked how you manage this definitively. You can't just say, "Oh, I'm not an elbow surgeon. I'm not an upper limb surgeon." I would ask they'll just say, "Okay, well, you are the upper limb surgeon. There's no one else around. You're going to leave it without surgery?" And the answer is no. Okay, these are one of the few cases, a bit like NOS really. A terrible triad or unstable fracture dislocation of the elbow nearly always gets managed surgically. So they may show you an X-ray like this. If they do show you an X-ray like this, right, you can obviously see the radial neck fracture, but often the coronoid fractures miss. So you can see that. I'm not sure whether you can't see my my cursor, but the coronoid fracture usually goes with the distal humerus. So just keep an eye out for that, and just mention that, right? And mention the fact that it's dislocated. It's very simple stuff. You're not gonna, you shouldn't miss that before moving on. So they may ask you, what do you see? What are the stabilizers of the elbow? How do you assess this patient? These are all reasonable questions. Why would you get a CT? And these are my answers. So the elbow stabilizers, essentially, you've got the lateral and the collateral, or the lateral ligamentous complex, the anterior bundle of the MCL, and the ulnar humeral joint. Then you've got other stabilizers, such as the radiocapitellar joint, the common flexor and common extensor origins. A lot of people have moved away from this, which you'll see later in my talk. This is coined the O'Driscoll fortress of elbow stability, to start talking about the column concept. So there's 3 columns in the elbow. You've got the lateral column, which is essentially your radiocapitellar articulation, as well as your lateral and the collateral ligament. You've got your medial column, which is your anteromedial facet of your coronoid, and your anterior bundle of medial collateral ligament. You've got your middle column, which is your anterolateral facet of your coronoid. How do you assess the patient? Again, not difficult, but just know that most of these are unstable in extension and supination. So you could say, I would, after making my assessment, I would reduce it in A&E resus and immobilize it in flexion and pronation. And you could say, because that's usually the position of stability, and I would confirm that with a check X-ray or something along those lines. I think a CT is really valuable in these cases, in particular to look at the coronoid fracture, because which bit of that fracture determines how you manage this. So they may ask you, they won't ask you how do you classify coronoid fractures, but you may wish to volunteer classification of coronoid fractures, because that again can demonstrate knowledge in a very simple way. Or they may ask you, how would you treat this patient surgically? They may ask you about the approaches, and then they may ask you about if it's still unstable in theatre, what you're going to do. So try not to talk about the Regan and Morrow classification, the tip, less than 50%, more than 50%, because that's really old fashioned and no one really uses that. O'Driscoll then, in the same group in Mayo, did come out with a new classification, which again uses the term tip as a type 1. Really, there is no tip to the coronoid. It looks like there's a tip on the lateral X-ray, but there is no tip. It's a fan-shaped structure. So it's better to think of it as the anterolateral facet, the anteromedial facet, or basal, which includes both facets. And in the anteromedial facet, and O'Driscoll, to his credit, did actually talk about this in his new classification. Whether it involves a sublime tubercle or not is important because that's where the attachment of the MCL is. But just knowing that is useful, and just think anteromedial facet almost always needs to be addressed surgically. You can't just leave that. It's not a tip fracture. That's a very important part of the medial column. How do you treat the patient surgically? Pretty stock answer there, but essentially most people would start on the lateral side. They would repair the lateral undercollateral ligament. They would repair or fix the radial head. Don't be afraid to replace it. If you think it's really smashed, you can mention that. And then you have to then assess the stability of the elbow after you've done everything on the lateral side. You basically do that in full extension, full flexion, full supination, full pronation. And like I said before, these tend to come out in extension and supination. Now you got to remember the patient's anesthetized, and one of the stabilizers, dynamic stabilizers to the elbow, are the column flexor and common extensor origins, okay? Because they span the elbow, and there's usually some resting muscle tone from those muscles. And so elbows generally will be a little bit more stable once the patient is mobilized, right? And that's why we don't, one of the many great reasons why we don't splint elbows after a fracture dislocation. You want them to be firing their muscles to help stabilize the ulnar-humeral articulation. And so the reason why I mentioned that is because when they're fully relaxed, the elbow may be slightly more unstable because of no contribution of those dynamic stabilizers. Nevertheless, it should still be in joint within 30 degrees of flexion. Okay, so near full extension, when you take a lateral X-ray, there should be no sagging, there should be congruence of the ulnar-humeral articulation. If there's not, then you've got to address the only thing that you've not addressed by going on the lateral side, which is the anterior bundle of the MCL. And so you do that from a medial approach. My preference is to do the Hotchkiss approach, but you can do any approach you like, as long as you identify and protect the ulnar nerve. They may ask you what approach you use for the lateral side. Again, it doesn't really matter because everything's kind of, there's a big hematoma there, everything's kind of pulled off, and so the planes are all over the place. As long as you understand that more commonly than not, the lateral undercollateral ligament is pulled off the humerus, and you don't want to do an approach where you're also taking it off distally, because then you've created a bipolar ulnar-collateral ligament injury. So that's why my preference is for the Kaplan. This is the revised O'Driscoll classification, but if you really wanted to show off, you may wish to talk about the Wrightington classification, because this, to me, is the most logical way to think of fracture dislocations. And the good thing about the Wrightington classification is it's intuitive and it tells you exactly what you need to do for these. But the vast majority of these are C, terminal C. So there's a radial head fracture, and there's an anterior lateral facet fracture of the coronary, which you can leave in a lot of patients. All right, if it's a small fragment in particular. Anyone who knows me knows that I'm a big fan of anatomy, and I'm a big fan of surgical dissection. And I just wanted to give a shout out to this gentleman who's a professor in Barcelona, I believe, called Pau Galano, who passed away a few years ago. He has by far done the best dissections in the human anatomy, I think, ever, and in the history of anatomy, to be honest. If you look at his work, his body of work, it's phenomenal. But he's got some really good ones on the Springer website for the elbow. And so you can see here, there's obviously the medial side, the anterior bundle, which is on the bottom left, number 16. It goes from the isometric point of the medial epicondyle all the way to the sublime tubercle. It's got quite a wide footprint, as measured in 9 on the right hand side, and that's really the more important one. That's the one that tends to tear. If you ever, just out of pure curiosity, if you're ever in a situation with your boss where you've seen taken to theatre and the patient is unstable in flexion and pronation, which is the opposite to what you would normally expect, that's usually an injury to number 5 on the right, which is the posterior bundle, but that's incredibly rare. But yeah, these dissections are fantastic. This is the lateral side, and you can see the lateral ligamentous complex is really one big mesh of tissue, but it's formed from distinct structures. You've got the radial collateral ligament, which is number 13 on bottom left. You've got the lateral ulnar collateral ligament, which is number 14, which goes from the midpoint of the capitellum laterally on the lateral epicondyle to the supinator crest. And then you've got an accessory ligament, which is really a blending and extension of the annular ligament. This is a Driscoll fortress. It's kind of old-fashioned. You can see 1999 this was made. But this is how he talked about it. But essentially, all of these things are important. But I would urge you to look at the 3-column concept from the Wrightington classification, which is a really nice way to look at it. So the key to this station is to move through the station. Don't get bogged down with ATLS. Don't get bogged down with describing, there's a coronoid fracture and this fracture and that injury. Just try and get to theatre and definitively manage it whilst picking up all the pertinent points along the way. To really do well in this station, you've got to understand how the elbow is stabilized. And then you do really need to know how you're going to approach the bits that are injured and be able to describe them quite quickly. Okay, next case, Monteggia fracture. So usually the trauma viva, again, standard trauma approach, however you choose to write that down and recite it in the beginning. It's really a good station for knowing a classification. I think I keep saying that a lot, but I just find it's just a really easy way to anchor your knowledge if you know a good classification for this. And if the fracture is often straightforward, if they show you a pretty straightforward then fracture, then the scenario is not going to end with you fixing it perfectly and everyone goes home high-fiving each other, right? If it looks like it's straightforward, then it usually will be more to the scenario, usually in the form of dealing with a complication that occurs later, and they can choose any one of a number of things. So they may show you an X-ray like this, pretty typical, sort of an anterior fracture dislocation, Monteggia variant. What do you see? Very simple description. How do you classify? Again, they won't ask you to classify it, but you may offer to classify it. And then how do you assess this in ED? Pretty straightforward beginning question. And these are my stock answers. So Beto classified this 1967 into 4 types. So this is type 1, which is anterior, type 2 is posterior, type 3 is lateral, and type 4 is with a radial fracture. And then if you wanted to dazzle them with your knowledge, type 2 fractures, which are the more common ones, the posterior ones, was further reclassified by Jesse Jupiter in 1991 into A to D. So I'll explain what those are later, but this is obviously an anterior fracture. If you're doing reasonably well, they may throw in this curveball early on in the scenario, what's the mechanism of injury for something like this? Well, then they will usually move on to how would you treat this patient after you've gotten out of ED. So the mechanism, there's 3 mechanisms described. There's a hyperpronation, there's a hyperextension plus biceps contracture, and there's a direct posterior trauma. But in reality, the patient's not going to know what happened. It's usually quite a fast event that occurs that leads to this. How do you treat the patient? Again, the vast majority of these are treated surgically. Even those that aren't particularly fit for surgery would probably be managed under regional anesthesia in some centers. But again, choose to do this however you like. I prefer lateral to keep this position and a midline incision, which I think is pretty standard, to be honest. And identify, protect the on the nerve, obviously reduce it, hold it with K wires, check with II that it's reduced and the radial head reduced, and then go ahead to fix the ulnar using anatomic plate. So then this is where the scenario really gets a bit more meat to it. So they may ask you, okay, you fixed your ulnar and the radial head's still dislocated. You should expect this to be a natural step progression in this kind of station, especially if the fracture is relatively straightforward. And then after you revise it, it's still dislocated. What do you do now? And these are my answers. So first, I'll check your reduction. So basically what they're asking you, if it's still dislocated, they're asking you to understand and explain what is the normal anatomy of the proximal ulnar. And you should know that it's not straight. And so usually what happens is it gets fixed in a straight position, it gets fixed in extension with a kind of an apex anterior deformity, and that forces the radial head to stay out. So you need to basically just say, if they do present you, I just say, look, I would look at my reduction. Especially if it's comminuted and it's hard to get a cortical read, you need to just be aware that you may not have fixed the ulnar correctly, and that's why the radius is still out. So that you may say, oh, well, I've checked it, it's perfect. Or they may say, yeah, you check it, the reduction is absolutely spot on, it's still dislocated, what are you going to do? And then you basically say, look, you'd have to then approach it to see if the annual ligament is incarcerated. Or it could be anything that's incarcerated, but usually the annual ligament is incarcerated into the radiocapitellar joint. And so then they ask you, how would you address that? And again, it's just understanding the approaches to the lateral elbow. This is the classification, the beta on the left, so type 1 to 4. And then this is Jesse Jupiter's modification for type 2s. So 2A is this triangular fragment involving the coronoid. 2B is at the metaphysis. C is at the diaphysis, and D is comminuted. So again, I mentioned this, but you need to understand that there's something called a PUDA, which I didn't understand what it was until I started looking up for the FRCS. But essentially, the proximal ulnar has a slight flexion attitude to it compared to the diaphysis, and that angle is the PUDA, the proximal ulnar diaphyseal angle. And X-ray studies that describe it will describe it as being around 6, 7, 8, 9 degrees. This study from South Korea used 3D CTs on 20 cadavers, and they described it as much lower, so around 4 degrees. But you'll notice next time you look at your proximal ulnar plate, not your electron plate, but your proximal ulnar plates on your systems, you'll find that it's got a slight curve to it. And there's also a varus angle. Again, that's more important actually in peds with plastic deformation of the ulnar and radial head dislocations. But there's a varus angle of 12 degrees as well. So you basically need to understand that if the radial head is dislocated after you fixed it, you may not have correctly restored the PUDA. So the top tips, the fracture in its management is usually not the difficult part here. It's dealing with the complication at the end, and it may be the radial head still dislocated, it may be a nerve injury, it may be heterotropic ossification, whatever it is, it's usually a bit more to it than that, because there's probably not enough there to really flesh it out to be a full station, or maybe not, I don't know. And you basically need to understand the proximal ulnar anatomy, as I mentioned. So next is a smashed distal humerus. They may present this in an elderly person or a young person, doesn't really matter, but you need to basically use your standard trauma approach. It may be an open fracture, so you need to understand the Bose guidelines. And you need to understand how they differ for upper limb and lower limb fractures, okay? For upper limb fractures, it does not say send everything to a trauma center, believe it or not, because most of the time you can get coverage in most upper limb open fractures, but it really does depend on the scenario. If they show you a really mangled limb and polytrauma case, it's clearly going to an MTC. But if they just show you a little old lady who fell with a little puncture wound, then you need to understand and show awareness that what the Bose guidelines say and mention that. You need to understand the principles of ORIF, of surgery here. And I would say to score highly or to get to the higher marks, or even the scenario may call for it, they may push you down the route of an elderly person with a very comminuted fracture and what you're going to do for them. They may show you any one of a number of these x-rays, right? Usually the ones on the left. So, osteoporotic elderly person with that injury is a very different proposition to a 21-year-old who came off a motorbike with that injury. Okay, you treat them differently. I'm just going to labor the point a little bit here because I think a lot of people don't understand this principle or haven't come across it, and I think it's important. So this chap O'Driscoll, very famous elbow surgeon in Mayo Clinic in Rochester, Minnesota. In 2005, JSCS, he published this paper, which is really a seminal paper in elbow surgery and in trauma surgery. And he talked about this keystone concept to the distal humerus. And he was a big advocate for parallel plating, which is this plating construct. And he basically came up with a set of rules to fix these injuries surgically without a high rate of failure. And at the time, this is right when locking plate technology was coming out. This is when titanium plates were coming out, and actually with the old recon plates, and old DCP plates, this injury was really difficult to treat well, and the rate of fixation failure was incredibly high. So there was a need for these principles He's a little bit dogmatic about how you should manage this, and I think there's more than one way to skin a cat, but I think understanding the principles of fixation as described by him is very useful to know. So he talks about these key techniques, and so I call them golden rules. So he says every screw should in the distal fragment should pass through a plate. That doesn't always happen, but there's a good reason for that, because you create a much stiffer and much stronger construct in doing that. Every screw in the distal fragment should be anchored in a fragment on the opposite side that is also fixed by a plate. So basically try and create screws that go from the plate across both columns. As many screws as possible in the distal fragment. This goes back to fragment fixation failure in the older techniques. And you'll see that now most of the plating systems for the distal humerus now have a cluster of holes at the distal end to help accommodate this. Every screw should be as long as possible, not out of the bone, but basically angled in a trajectory that will give you the longest length. Every screw should engage as many articular fragments as possible. The plate should be applied in compression at the supracondylar level. That's really important to squeeze the condyles together. And the screws into the distal fragment should lock into each other by interdigitating. And the final golden rule is that the plate should be strong and stiff enough to resist bend and breakage, which really isn't a problem these days because all the modern implants are designed to be strong and stiff enough to do this. You need to know about approaches, and there's lots of different approaches to the elbow. They may ask you for something like this. This is a paratricipital approach showing both windows. You probably wouldn't use this in a very comminuted distal articular distal humerus fracture, but you may do in a supracondylar or a simple fracture type. You may do a osteotomy, and they may ask you where you do your osteotomy, whether you do a straight cut or a chevron. And the answer is you do it in the bare area, because there's an area where it's not covered by articular cartilage, so you're not rogering the joint by doing that. And then a chevron osteotomy just increases your surface area for healing. This used to be the mainstay of approach for me until I worked for Duncan Tennant and Yemi Pierce at St. George's, and they totally changed my view on approaches for distal humerus fractures. And now I don't take off the olecranon at all for these, and I'll show you why later. But essentially, this is a perfect mold for your distal humerus articulation. And so if you lose that by doing an osteotomy, you may think you fixed the fracture perfectly, which is hard to do in very comminuted fractures. You come to put your osteotomy back together, and it doesn't fit. And it doesn't fit not because you haven't lined it up properly, but because you haven't reduced your distal humerus correctly. And so keeping the olecranon on gives you that mold to basically then continuously check and double check and cycle the trochlea onto the humerus, just to actually see whether you've reduced it correctly. So you could do something like this, which is a lot of people used to do for elbow replacements, where you basically just reflect everything from medial to lateral. Or you could do a midline split through the muscle. That's a Campbell's approach on the left. Or what my go-to is now for these fractures is what is seen on the right. This is the Van Gordon modification of the Campbell's approach, where you basically take the aponeurosis in a rectangular tongue. So you keep it attached to the olecranon, and you reflect just the aponeurosis, so you can see the deep head of the triceps there, and then you do a midline split like you do a Campbell's, and then you extend that medially and laterally as much as you need to get as much exposure. And that will actually allow you to sublux the ulna if you wish. You can put a towel clip on it and move it out of the way, or what I tend to do is I put a swab, a small unfolded swab around the bare area, and use that as a handle to pull the ulna out of the way. And if you flex the elbow, you can see all of the articular surface. And the benefit of that is then you've got your exposure, you can fix everything you want to fix, but you've also left your olecranon on, which gives you an idea of assessment of your reduction at the end. And it also doesn't, means that you don't have to do another operation at the end, which is the osteotomy fixation. In frail elderly patients, they may push you down the route of talking about elbow replacements for distal humerus fractures. which is certainly an option for sort of irreparable fractures, very comminuted patients. And there was this RCT, which is quite small in number, which basically showed that there was an improved Mayo elbow performance score when you did an elbow replacement over fixation. And this was done in Canada. There was no difference in DASH, and there was no difference in reoperation. But it's important they randomized intraoperatively, and they only included ones that essentially could be fixed with either or. So they had to exclude some that were just not fixable. But there's another RCT that's currently underway looking at this, I think from Korea. They may talk about hemis if you do really, really well. It's relatively new, to be honest. This is a hemiarthroplasty. Essentially, it's one half of a total elbow replacement system. And my understanding is there's only one system that allows you to do this, currently sold in the UK. And it's this one here. This is I think the latitude. And that's because the humeral component also has a bit for the capitellum, which a lot of them don't. And if you don't have that, it'll be unstable. And managing the collateral ligaments is very important here. Otherwise, the thing will be unstable. But this is a pretty good alternative. Some people prefer this over elbow replacements because they say that you don't have to protect them as much, although that's not really been proven as such. A lot of people think if you're going to go through the hassle of doing a hemi, you might as well just do a total, because it's it's not much more time to prepare the ulnar and put a component in there. Anyway, top tips for this is get a CT in most cases. I think that would be pretty much expected. Understand the principles of fixation, have a preference of your approach. There's no right or wrong, but you've got to have a good thought process as to why you've chosen one over the other. Parallel plating versus 90-90 doesn't matter. You just got to explain your rationale. There are some, I prefer parallel plating for most, but there are some fractures where it's really advantageous to also have a posterolateral column plate. So then I'd do 90-90. It really just depends on the fracture pattern. So, try not to be dogmatic, but try to have a good reason for why you've chosen a certain thing. And expose and identify the ulnar nerve in every case. You don't have to transpose it, you just have to protect it throughout the fixation. Especially when you're putting a medial plate on, because it gets right in the way, and you've got to be confident that you haven't put it underneath your plate or it's stretched over your plate. And then finally, I've got two more cases. Capitellar shear fracture, they may show you this. Again, not that common of an injury, but it's quite easy to get asked some questions about this. They may just show you the AP. It's not that obvious to see. And as soon as you ask for the lateral, it's pretty obvious what you're looking at here. Again, you don't need to know the classifications, but this one is particularly useful. So, Dubely et al. Essentially, type 1 is just a capitellar shear. Type 2 is basically extends and involves some of the trochlea, but it's one fragment. And type 3 is both the trochlea and the capitellum are fractured, but they're separate fragments. The key important thing with this classification is that these subtypes A and B. So A, there's no posterior comminution. B, there is posterior comminution, and that's incredibly important. The ones with posterior comminution are a lot harder to treat, and they should be treated slightly differently. I would argue. So the vast majority don't have posterior comminution, and so you can use headless compression screws like this. But if they do have posterior comminution, you really should be supplementing that with a posterior lateral column plate. So the top tips for this scenario is always ask for orthogonal views, get a CT if you're unsure, look for the radial head because that can also be fractured in these injuries, and fix in a way that will allow you to immediately mobilize the elbow. Okay, never put an elbow in a splint or a cast. All right, it's just counterintuitive to the function of the elbow. It's not just all about stiffness. It will potentially sublux in that splint or cast, and so you want to try and avoid that and get them moving straight away. Final case, they may show something like this. They may say, oh, this guy was a manual laborer, was lifting something heavy, some sort of mechanism of eccentric load, overloading of the biceps, and then he felt a pop and has got bruising, or may not have any bruising. I got this in my trauma viva. They'll ask you how you assess it clinically, and they'll basically want you to talk about the hook test. That's what everyone seems to know. It's like one of 20 tests for the distal biceps, but this is how you do it. And you're hooking from the lateral side. They'll often ask you that in the FRCS. They'll ask you which side is the hook test done from. Is it from the medial side or from the lateral side? It was described from the lateral side. And you can get a false negative if you hook the aponeurosis, and it's hard to know when you've done that a lot of the time. There's also the resisted hook test, which has been evaluated by various surgeons, including Roger van Riet in Antwerp, and that's quite sensitive even for partial tears, where you basically do the hook test and then you get them to supinate against you resisting them. So you're basically trying to pronate the forearm. And pain is a positive sign for the resisted hook test. But for the complete ruptures, the hook test is essentially what you're looking for. These are some of the other tests described, but this is the one that you're really looking at. Then they'll ask you, okay, well, if you don't treat it surgically, what's the likely loss of strength? And it's supination more than flexion. As we know, biceps is a supinator principally, whilst brachialis is the principal flexor. And this study is quite nice. I think a lot of the figures banded around in author bullets and by other surgeons over-represent the amount of supination strength and flexion lost. This study looked at, I think, over 50 studies on distal biceps, and they included 6 that included a conservative arm, and they basically came up with these figures. So 62.7% supination strength compared to normal, and if you operate on them, that goes up to 89%, so not 100%. Again, 83% flexion strength if you treat it conservatively, and that goes up to 95% if you treat it operatively. They might ask you how you'd fix it. There's lots of different ways: a single incision or double incision. Most surgeons now are preferring a single incision technique, and FRCS have come along and created this very beautiful system, very simple to deploy tension slide technique, and have really made it a lot easier for the surgeon that doesn't do that many of these, for sure. So this uses an endo button technique. Some people use anchors, some people use an endo button on its own, unicortical, bicortical. Some people use a tenodesis screw and an endo button. It doesn't really matter what your preference is, just as long as you can describe the approach and the general principle of how you would fix the distal biceps, how you'd find it, how you would prepare the footprint, whether you use fluoroscopy to make sure you're centered. You need to learn about the complications, as I mentioned there. The top tips, the clinical tests to make the diagnosis. Essentially, you don't rely on imaging. The hook test is from the radial side. MRI cases only for when it's equivocal or when it's slightly chronic or where you can't feel the tendon stump. You may wish to get that to allow you to prepare appropriately for plan B and plan C in theatre. And remember, not everyone needs a repair. 2/3 supination strength for a lot of people, unless you're doing a lot of repetitive supination with requiring force, a lot of slightly older patients probably won't need a distal biceps repair. So that's my top tips for the exam. Those are the objectives that we covered. And then the next half is basically we'll turn off the recording and we'll get people who volunteered to go through some Viva practice.
We have some questions.
Oh, yes, please.
So someone asked, what is Mubarak index and what is its significance?
I'm not familiar with that. I don't know.
Okay. Okay, that's the only question so far. Okay, so
if anyone has any questions, you can write them in now whilst we're preparing the next bit of the session. Was that okay, Hani?
Yeah.
Okay.
Okay, so let's stop recording now.